Вітаю всіх учасників сьогоднішньої зустрічі. Я Оксана Zbitneva, керівниця Координаційного центру з психічного здоров'я Кабінету міністрів України. Ми є імплементаційним партнером впровадження всеукраїнської програми ментального здоров'я ТИЯК, яка в Україні реалізується за ініціативи першої леді України Олени Зеленської. Я рада вітати вас всіх, дорогі учасники, з усіх куточків України. І шалено втішена тим, що бачу серед учасників 500 людей, фахівців, які прийшли вже всьоме на наші зустрічі, на наші вебінари, для того, щоб дізнатися щось нового від провідних експертів світу. Цей проєкт про спеціалізовані послуги для дітей і підлітків у сфері ментального здоров'я ми реалізуємо за підтримки і допомозі з організацією і натхненника професора Йорга Фегерта, який очолює Європейське товариство дитячої та підліткової психіатрії, за що йому дуже вдячні. Нагадаю також, що цей проєкт є під патронатом перших леді Німеччини і України, що дуже є для нас цінним. І нагадаю, що наш безцінний партнер, дитячий фонд ООН ЮНІСЕФ, допомагає нам з організацією, технічною підтримкою і з тим, щоб ті учасники, які не змогли цей вечір і попередні потрапити на наші вебінари, змогли отримати відео і переглянути це потім, попрацювати потім. Я дякую нашій неймовірній, фантастичній аудиторії фахівців, тому що кожного вебінару ви маєте велику активність. Ми отримуємо безліч запитань, і з цих вебінарів виростають окремі ініціативи, про які ви запитуєте, якісь корисні продукти, які потребують адаптації, перекладу українською. І ми, як координаційний центр, цим будемо займатися в подальшому. І сподіваюся, що скоро вам представимо ці продукти. У нас сьогодні тема, яка є дуже затребуваною в Україні. І не лише в Україні, але для наших фахівців вона є важливою. Ми отримали розуміння та потреби в цій темі від вас всіх. Тому сьогодні про розлад дефіциту уваги і гіперактивності. І з нами сьогодні професор Tobias Banaschewski, один з провідних фахівців у сфері дитячої та підліткової психіатрії, який займає посаду медичного директора Центрального інституту психічного здоров'я в Маннхаймі, Німеччина. Професор Тобіас, за хвилину, за секунду передаю вам слово, але хотіла би ще окремо подякувати пані Катерину Булавінову, медичного експерту дитячого фонду ООН ЮНІСЕФ в Україні, і команду, яка забезпечує можливість нашого сьогоднішнього спілкування. Пані Катерино, передаю вам слово і всім тихого, мирного вечора, щоб ми з вами могли спокійно попрацювати. Дякую і наснаги.
Okay. I assume that you can see my title slide, Attention Deficit Hyperactivity Disorder and Update. If not, then just let me know. And I'm very happy to talk. Okay, perfect. I'm very happy to share, to talk to you, and I really want to tell you that I'm very sorry about the situation in the Ukraine, which is, as you, I don't need to tell you anything about it, but a disaster. But my condolences and sympathy to you, and also support. That's what I wanted to say up front. Now here are the disclosures of my talk. I have been in an advisory or consultancy role for a couple of companies, and I also have given talks for money, but it's just there's nothing particular about this. Now, I will start a little bit with the overview on the prevalence, and then move towards the etiology and what we know about ADHD etiology, and then later talk about how what the impact of ADHD on the patient is, and how we can best treat ADHD. So it's quite clear from a lot of epidemiological studies, and as you can see, this meta-analysis done by Guilherme Polanczyk is already more than nearly 2 decades old, but still the figures still hold. The epidemiological prevalence around the world is quite similar. So ADHD is a frequent disorder affecting about 3 to 6% of the population. There are more children than adults, which is due to the fact that some children and adolescents do no longer fulfill the diagnostic criteria if they grow up. So it's not that you once such a disorder like ADHD is diagnosed in children, that it will be necessarily a lifelong disorder. I was talking about the epidemiological prevalence. As you can see, 3 to 5% or 6% in children and adolescents. In adults, it's around 3%. But then if you look into the administrative prevalence, and administrative prevalence is how many of the population do receive actually a diagnosis and are treated in the system. You can see that in parts of the US, many more children do receive a diagnosis than you would expect based on epidemiological studies. This is not as different here in California, for example, but here in the Midwestern states, many more children receive a diagnosis than you would assume should receive a diagnosis. And the figures have been increasing during this is an old study and already, but it's still the situation.
Але ситуація надалі є чинною. За останні 20 років кількість діагностованих випадків збільшилась. Те саме стосується кількості дітей, які отримують фармакологічне лікування, медикаментозне лікування РДУХ.
І that there is a huge variation between the different US states, and this has been analyzed where this does come from. And this is and has nothing to do with, let's say, density of doctors or ethnic issues or income or
населення на тисячу населення або із соціоекономічним статусом, або з якимись етнічними даними і так далі. Але основний чинник, який відповідає за відмінності у частоті діагностики і також кількості дітей, які отримують лікування між різними штатами, то цим чинником є спільна політика. Ті штати, у яких є велика кількість діагностованих випадків, це ті штати, які мають певні нормативні акти І якщо школи не виконують цих нормативів, або якщо вони виконуються нижче середнього, то тоді на ці школи накладаються певні санкції. І є така тенденція у суспільстві, схильність, що школи, вони примушують, так би мовити, батьків, щоб відвести дитину до лікаря, щоб провести діагностику. І я показую ці два слайди, щоб наголосити на такому. З одного боку, РДУХ – це є розлад нейророзвитку із дуже схожими по всьому світові показниками поширеності тощо. Але з іншого боку, соціальні, суспільні чинники завжди відіграють свою роль, якщо ми говоримо про питання того, хто отримує діагноз, кому ставлять діагноз розладу дефіциту уваги та гіперактивності. І ці показники, якщо ми говоримо про діагноз і поширеність, це не виключно фактори, пов'язані тільки з пацієнтом. Якщо говорити про етіологію, що ми знаємо про це ми говорили про епідеміологію. Зараз про етіологію РДУХ. Є численні дослідження близнюків, генетичні дослідження, які свідчать про те, що РДУХ має істотний генетичний спадковий компонент. Що це означає? Це означає, що гени, вони є етіологічно релевантними, але це не означає, що чинники середовища є нерелевантними, тому що успадковуваність, яка є показником частки варіантів у популяції, які можна пояснити генетичними чинниками і взаємодією між генетикою і середовищем. Тобто навіть у самому понятті успадковуваності чинники середовища вже відіграють свою роль. І зверніть увагу, що коефіцієнти успадкованості для будь-якого розладу можуть змінюватися, якщо середовище змінюється, або якщо генетичний склад популяції так само змінюється. Якщо б, наприклад, у нас були ідентичні клони, то усі варіації, які би залишалися, між ними, то вони би викликалися факторами середовища. Якби у кожної дитини були найкращі можливості для розвитку власного потенціалу, то тоді всі інші відмінності, вони би пояснювалися генетикою. Отже, дослідження близнюків говорять про те, що гени є важливими, це не несподіванка зовсім, і ми провели численні так звані геномні дослідження по всьому геному для того, щоб виявити ті варіанти ризику, які залучені у патофізіологію РДУХ. І на цьому слайді, це з 2018 року з дослідження, у 2018 році було 20 тисяч випадків, 35 тисяч теж у контрольній групі було, і на основі цього аналізу вдалося виявити 12 локусів, які дійсно мали істотність для всього геному. І ці гени, які були виявлені, вони корелюють із генами, і вони впливають на інші риси. Наприклад, якщо ми розпочнемо зверху, тут ми бачимо освіта, рівень IQ. Це негативна кореляція, це не є висока кореляція. Якщо говорити про навчання, є певна позитивна теж кореляція. Тут ми бачимо різноманітні психічні розлади і також розлади харчування. І також ми бачимо кореляцію з курінням, негативна кореляція із віком першої дитини. Тобто, якщо є ердух, то є більша ймовірність раніше передати ердух дитині. Отже, ці результати цього метааналізу, вони були оновлені у 23-му році, і тепер ми вже виявили 27 локусів ризику, і, звичайно, це вдосконалює генетичну архітектуру ердух. І цікаво зазначити, що багато із цих генів, які були виявлені, вони, відповідно, також вони не є істотними, але потенційно вони можуть стати істотними, якщо розмір вибірки підвищується. І це стосується раннього розвитку головного мозку. І ми можемо зробити висновок, що ранній розвиток головного мозку дійсно відіграє роль у етіології розладу дефіциту уваги і гіперактивності, і цей розлад тепер, він уже переходить до частини розладів нейророзвитку. І тут ви бачите, що ми виявляємо дедалі більше генів. І важливо враховувати таке: якщо є численні фактори ризику, які впливають на певні кількісні характеристики, і якщо ці фактори ризику, вони не об'єднуються в кластери, то, можливо, ви будете у вас буде вдача, і вам пощастить із фактором ризику А, але не пощастить із фактором ризику Б, тощо. І який є результат цього? Результат такий, що у популяції ви бачите ось ці криві, так? Ви бачите ось таку ось такий розподіл, так, нерівний, що більшість суб'єктів популяції вони десь посередині, і тільки декілька представників популяції є на цих краях цієї кривої, там, де у нас є тяжкий випадок ердух, або ті, які можуть абсолютно ідеально концентруватися. І це також нам говорить про те, як генетичні результати, що ердух – це є патофізіологічно і також клінічно гетерогенним розладом. І його викликають численні фактори, і його можна вважати разом, так, в сукупності, як вираження вразливості, що є розподілена за різними вимірами. Тобто йдеться не про те, що є якісь чіткі межі. Це більше, знаєте, як із гіпертензією, високим артеріальним тиском. Тобто треба десь провести цю риску. І запитання, власне, де ми проводимо цю риску, цю лінію, так, малюємо. І має сенс провести цю лінію, якщо симптоми браку уваги, браку імпульсивності і гіперактивності, якщо вони викликають функціональні порушення, а не якщо ви там іноді про щось забуваєте, це не ердух. Отже, ердух є гетерогенним розладом, і у більшості випадків, більшість випадків викликаються спільними варіантами, поширеними варіантами, які роблять свій внесок у, тобто кожен із цих варіантів, він робить свій внесок тільки незначний у сукупний ризик розвитку ердух. Але є також певні рідкісні хромосомні аномалії або рідкісні або варіанти кількості копій із низькою частотою, які сильніше впливають на РДУХ. Але оскільки вони є рідкісними, то вони не відповідають за таку велику кількість випадків серед популяції. Також цікаво, якщо подивитися на генетику, що залежно від, наприклад, якщо ми говоримо про дитину з РДУХ, то є вищий збіг із гіперактивністю і аутизмом у порівнянні із РДУХ, який діагностований у старшому віці. І якщо РДУХ діагностується у старшому віці, то він більше має генетичний збіг із депресією, більше, ніж РДУХ діагностований в дитинстві. І це означає, який ми можемо зробити висновок? Висновок такий, що РДУХ – це не просто РДУХ, але що є різні, що РДУХ сам собою є гетерогенним. І діагноз РДУХ говорить вам тільки те, що є певний кластер або паттерн симптомів, які є наявними у цього індивіда, але він нічого не каже про конкретну етіологію. Тепер я говорив про генетику, але також можна поставити запитання, а що ми знаємо про чинники середовища, ризики, які є в середовищі, які можуть вплинути на розвиток РДУХ. І якщо стисло говорити, загалом, то є певні ризики середовища, які чітко викликають РДУХ, але більшість факторів ризику середовища, які асоційовані із РДУХ, ми не знаємо напевно, чи вони є просто ризиком, чи вони є фактором, що спричинює РДУХ. Тобто, наприклад, куріння у матері або стрес у матері, вони асоційовані із РДУХ, але чи йдеться тут про генетичну схильність матері, чи вона просто генетично схильна більше до куріння, але також має більшу схильність передати гени РДУХ дитині. Тобто ми не знаємо, чи куріння матері як таке само собою є фактором ризику однозначним, який є причинним. Всі ці перелічені фактори, вони пов'язані, асоційовані, але ми не можемо, напевно, сказати, чи це є причинними факторами. Так само фактори харчування, що ми точно знаємо, що депривація, тяжка рання депривація, то це, ймовірно, є ризиком фактору причинним. І ми знаємо це із дослідження на дітях у Румунії, яких було взято у родини. Тобто, після того, як повалено було режим Чаушеску, то із сиротинців, де діти жили в жахливих умовах, то цих дітей, які жили в цих сиротинцях, їх усиновили, удочерили у Великій Британії. І пізніше ці діти, яких усиновили із румунських сиротинців, то їх порівнювали із англійськими дітьми, яких також було усиновлено чи удочерили, яких. І залежно від тривалості, тобто як довго дитина жила у цих сиротинцях, і тобто завжди їх туди брали після народження, так? І залежно від того, скільки вони жили у цих умовах, де вони були занедбані, так? То тим вищим був ризик розвитку РДУХ та інших ментальних розладів.
the brain networks,
Коли
which
ми
are
говоримо
involved, and I do not go
про мозок, а це те,
through all
чим
the
я
details here
займаюся,
now, but the core message
я не
is
буду, ну, тобто
that
про
there are
взаємодію мозкових
multiple
мереж я не буду
networks
сильно
which have
вдаватися в цю
been
тему, але є
found
кілька
to be
взаємодіючих
associated with
мозкових
ADHD.
мереж, які
But the
асоціюються з
forecortical
появою
brain
рдух.
regions, subcortical brain
Тобто
regions,
тут є кора головного
executive
мозку,
control networks, remote
мережа
network,
контролю,
alerting
мережа,
network, for example.
алертна мережа,
But none is specific for
мережа
ADHD.
винагороди, але ми не можемо
then,
сказати, що
also in
якась
terms of
конкретно
people,
відповідає за
the brain
виникнення
networks
рдух.
involved in ADHD pathophysiology, there's
Отже,
really a huge degree of heterogeneity.
ми говоримо про велику ступінь гетерогенності в цьому питанні. Що ми знаємо про розвиток мозку? Так це те, що в середньому спостерігається затримка дозрівання кори головного мозку, префронтальної кори при рду. Особливо префронтальна кора в групі з ADHD. Ви бачите, синя лінія – це діти, у яких діагностований рдух, а зелена лінія – це діти, які розвиваються типово. Тобто десь на 2 роки в середньому спостерігається відставання в дозріванні кори головного мозку.
Areas, particularly prefrontal cortex,
префронтальна кора, ми бачимо. Ось картинка справа. Ми бачимо, що видно доволі таку суттєву затримку. Як це впливає на поведінку? Діти, в яких є рдух, ведуть себе трошки не на свій вік, ведуть себе як діти молодшого віку. І є дійсно враження, що вони не настільки дорослі, дозрілі, як їхні однолітки. А вони схожі на дітей більш молодшого віку. І це робить, це лише частинка пазлу, який є доволі складним і цікавим, коли ми говоримо про рдух. Як ми знаємо, дофамінові нейрони грають роль в етіології рдуху, в захваті, тобто там є інгібітори дофаміну, що призводить до того, що вищий рівень дофаміну спостерігається в таких людей, або він довше затримується. А що ж дофамін робить для мозку, власне? В мережах він відповідає за виконавчу функцію, це точно. Але я хотів би наголосити на іншому важливому аспекті. Дофамін також важливий для системи винагороди. І це так не лише в людей, але майже в усіх тварин, не тільки в ссавців, але і в нижчих видів. Отже, якщо суб'єкт, тварина навіть отримує винагороду, яка є неочікуваною, тоді дофамінові нейрони підвищують частоту імпульсів. Якщо суб'єкт очікує цю нагороду, а потім цієї винагороди немає, то частота імпульсів в системі винагороди збільшується і зменшується. Що це означає, власне? Що зміна оцієї частоти імпульсів для дофамінових нейронів кодує помилку в часовому передбаченні. Тобто, Ти не можеш передбачити, що ти отримаєш в результаті. Це саме те, що кодується дофаміновими нейронами. То що відбувається? Нам потрібно отримати якийсь зворотній зв'язок від оточення, від середовища, щодо того, чи наші дії можуть бути успішними, чи ні. Чи ми робимо те, що треба, чи ні. Чи це призведе до невдачі. І це передумова будь-якого навчання. І ось через те, що ці дофамінові сигнали послаблюються у випадках з РДУХ, це пояснює, чому деяким індивидам важко навчатися. Їм потрібно більше часу. І у них спостерігається більше проблем не просто з концентрацією, а й з тим, щоб чогось навчитися. Вивчити певні звички, навички або перевчитися. Коли ми говоримо про нейропсихологію, ми спочатку думали, що це проблема, власне, захоплення, інгібіції. В кінці 90-х були різні моделі, потім вчені почали казати, що проблема не тільки з захватом. Це складніша система, що пацієнти з РДУХ, їм складніше, якщо винагорода затримується, якщо вони не можуть її отримати одразу ж. Їм складніше чекати. Пізніше була розроблена модель подвійних нейропсихологічних шляхів. Як ви бачите тут, є 4 різних моделі. Ми вже говоримо про множинні нейропсихологічні шляхи. І говоримо, що, можливо, їх дійсно може існувати більше, цих нейропсихологічних шляхів. На рівні нейропсихології ми бачимо доволі високу гетерогенність відповідно до дефіциту. І не обов'язково має бути дефіцит для того, щоб був РДУХ. І також є чудове дослідження, це мій друг доктор Когніл, який досліджував, як нейропсихологічне власне, як виглядає система? Ось модель того, що відбувається. Він дійшов висновку, що є певна відсутність зв'язку між зміною виконавчої функції та зміною симптомів. Тобто це не є обов'язковим, це не є поясненням. Як ви бачите, на моделі з часом, коли з'являється більше досліджень, картина стає дедалі складніше. Немає якогось одної чіткої, легкої відповіді. Не знаю чому. Слайди збилися. Вибачте. Де я був? Вибачте, зараз я спробую зрозуміти. Де я загубився? РДУХ є хронічним розладом, як я сказав, але також багато. Наскільки він буде залишатися з часом, наскільки він буде прогресувати чи ні, залежить від різних критеріїв. Там, де є певні якісь функціональні складнощі, це більш хронічні кейси. Або є випадки, які підпадають під повні діагностичні критерії. РДУХ асоціюється або пов'язаний з різними коморбідностями, з складнощами в різних сферах. Навіть смертність в більш ранньому віці, є надмірна вага, ожиріння, гіпертензія, злочинність, куріння, залежності, специфічні розлади навчання і виконавчої функції. Багато різних розладів, особливо тривожні розлади і розлади настрою. Але також з певними соціальними складнощами. Наприклад, подружні розлади, розставання, розлучення, проблеми з вихованням, проблеми з законом, арешти, ув'язнення, погані соціальні навички, порушені сімейні відносини, погані стосунки з однолітками, неприйняття однолітками, порушення психологічних функцій. У них нижча якість життя, низька самооцінка, суїцидальні думки, у них
suicide attempts and so on. In school, I already mentioned ADHD symptomatology is associated with underachievement. So if you have the same IQ, you are less likely to get the same grades if you have ADHD. There is more school expulsion and dropping out of school, so a lot of school problems. And later on, also reduced occupational performance, higher degree of unemployment, lower socioeconomic status, and a higher degree of risky behavior. So a point which is a fact which is highlighted frequently is the higher number of injuries, not just traffic accidents, but also other injuries. It's important to note that ADHD is frequently associated with emotional dysregulation. This means that you tend to be impatient, quick to anger, easily frustrated, but also easily excited, higher likelihood of losing temper or easily annoyed. That these symptoms of emotional impulsiveness or emotional dysregulations do occur to a higher degree in patients with ADHD as compared to normal controls. But as you can see here, those who do not with ADHD, if you diagnose ADHD in childhood, those who do not persist into adulthood as compared to the blue ones, those who do persist in adulthood, have substantially lower degrees of emotional dysregulation. What does this mean? So emotional dysregulation in children is a predictor of persistence and is also, as we know, an independent source of impairment. This is just to demonstrate what I already mentioned. that if you've got ADHD, you have a 50% higher chance of premature death. But if there are comorbid disorders plus ADHD, like ADHD, oppositional defiant or conduct disorder and substance use disorder, this risk increases dramatically, up to 8-fold. Now, what can we do once we to treat the symptoms of ADHD? Now I'm talking first about pharmacological treatment options and also clinical efficacy and safety. And there are multiple different, so basically the main key are stimulants. And stimulants, you can distinguish between methylphenidate preparations and dexamphetamine preparation. Lisdexamphetamine is just dexamphetamine, which is bound to leucine, and it's a long-acting form of dexamphetamine. So stimulants, you've got the noradrenaline reuptake inhibitor atomoxetine, and also alpha-2A agonist guanfacine. What you can say is all work have different, the treatment options for ADHD have different modes of action. They have different efficacies. Stimulants are more effective than atomoxetine and guanfacine. They have different pharmacokinetic profiles. So not just long-acting versus short-acting compounds, but then you've got the tolerability profiles are different, for example, between atomoxetine and guanfacine. And so you need to optimize the pharmacotherapy individually to the patient. But usually we start with stimulant, be it methylphenidate or be it dexamphetamine. And if you ask, should I start with methylphenidate or with dexamphetamine, then the answer is you can't really tell. Because for most patients respond to methylphenidate and dexamphetamine, or there's a proportion which there is no preference. 20% respond preferentially to dexamphetamine, and 20%, around 20%, respond preferentially to methylphenidate. And you know, of course, don't know upfront who does respond to what. And there's always a certain proportion of non-responders, about a third or 30%, who do not respond to methylphenidate or dexamphetamine. But if you use the one or the other, then you can receive a response rates up to 80 or 90%. The effect sizes, as I said, for stimulants, for amphetamine, may be moderately greater than for methylphenidate, but overall, clinically, that's not such an issue. You can say it's roughly, from a clinical point of view, you can they are equally effective. And this is also the result of a meta-analysis, network meta-analysis that we did, comparing all different types of medication, some which I do not mention because they are not really recommendable, and like bupropion or modafinil. There was a worry about the use of stimulant medications and the occurrence of sudden death. But this has been in the late 2000s, but this has been clearly ruled out that stimulants, if you prescribe them and if they are taken regularly if they are taken regularly according to prescription, they do not increase the risk of a sudden cardiac death. There are certain problems that you need to be aware. So overall, if you take stimulants for decades or for a longer time to treat children, then there can be not just appetite reduction, but there can also be a slight decrease in the height. And you can see, so for example, here the normal controls, they reached roughly 178 centimeters, but with ADHD, there was a 1 to 2 centimeter lower end height in males and also in females. And particularly if you take the medication consistently. We do know that methylphenidate treatment is not associated with a higher risk of suicide. The contrary is true. Treating ADHD may reduce the risk for suicide, but not increase. But there were certain studies suggesting that those treated with methylphenidate have a higher risk of suicide, but this was an artifact. Why? Because people usually come to a clinic if they are already in a bad mood or have certain problems. And then if you diagnose them and treat them, they are still in a worse situation than those who do not enter treatment. And this is why in the beginning you may see a higher rate of suicide in those who are newly treated. You can see from our analysis in a really huge cohort that during the time before methylphenidate treatment, the risk was 20-fold higher. And then during the first 90 days of methylphenidate treatment, the risk of suicide was still higher, but went down, and so on and so forth. And this is also in line with other studies. There is also no risk for psychosis. Usually no risk for psychosis if you treat with methylphenidate. And that we have done really large studies on this. So the overall incidence of psychotic events during methylphenidate exposure was 6 per 10,000 patient years, and no increased risk was found during the times of methylphenidate exposure compared to the periods with no exposure. Stimulants do reduce, if you treat ADHD with stimulant, this does reduce the risk of substance abuse within individuals by roughly 30%, and between individuals, if you compare those treated with those not treated, it's even higher. And you can also reduce the risk for criminality in around 30% to 40%. So during the periods when they receive medication, they commit or they are convicted to a lower degree, and a substantial risk reduction also in terms of serious vehicle accidents has been demonstrated. And for Sweden, this would mean that 50% of the in male patients, 50%, up to 50% of the accidents could have been prevented. What about non-pharmacological treatment options? Now, we did this meta-analysis in these series of meta-analysis already in 2012. And we are currently updating the meta-analysis, and this paper really changed guidelines, because before it was always, oh, you should first go for psychosocial treatment or for behavioral interventions before you go to medication. But then if you really study the in randomized controlled trials and investigate the other non-pharmacological treatment option, it's really, as you can see, in those who are, you do not find significant effects of these interventions. It does not rule out that there may be certain effects, but it's definitely not the case that you can say that these interventions are really very effective. Nevertheless, they should not be ignored, because for some patients and some caregivers, they may wish to try non-pharmacological interventions despite the limited evidence of efficacy instead of medication. Patients might be considered too young or to have, or if they have just a mild presentation, you may not want to give them medication. And some patients do not respond positively to medication, and medication alone may not produce the optimal results. And what I have forgotten to say, but what's really important, what's described here are the effects on the ADHD core symptoms. But as you know, ADHD is associated with multiple problems, let's say peer problems and being rejected by the peers, and so social interaction problems. And all this could be also part of a psychotherapeutical focus. And so you should not just rely on medication. And in particular, behavioral interventions, even if studied in a randomized controlled trial, blinded, so behavioral interventions do in fact increase positive parenting and decrease negative parenting, and this is very important as well. And reduce, even if you study it blinded, so if the rater is blinded, do reduce conduct problems. Now, I briefly tell what our German guidelines do tell. Currently, we are updating those. I'm the coordinator of the German guidelines for children and adolescents and adults with ADHD. There are multiple medical societies involved, like 20 or something, and also psychologists. So you should always give psychoeducation. You should usually start as first-line treatment, psychosocial treatment, if the children are below age 6. Only if they do not respond to psychosocial interventions like parent training, you may also consider stimulants. But if you give stimulants to very young children, not below age 3, and only by a specialist. And we are talking about stimulants and not about antipsychotics. Please note, antipsychotics are not indicated to treat ADHD. In children between age 6 and adolescents, so 6 to 18, if it's mild or moderate ADHD, you can still start with first-line psychosocial treatment, was our recommendation. But if it's moderate or severe, then you should go directly to medication. It doesn't mean that you cannot add psychosocial interventions, or you shouldn't add psychosocial interventions, but do not expect that severe ADHD symptoms respond very well to behavioral interventions. And in adults, first-line pharmacological treatment is indicated. Now, the first-line treatment is always stimulant, as I said. If there's a risk for substance misuse, you better go for long-acting stimulants. If a treatment is ineffective, like you start with dexamphetamine and it's ineffective, change to either the second stimulant, so either dex or methylphenidate, or to atomoxetine or guanfacine. But if it's not tolerated, the stimulant, then you should go directly to atomoxetine or guanfacine. But atomoxetine and guanfacine are usually only second-line treatments. Only if there are certain particular circumstances, they may not be. You may also consider to regard them as first line, like with tic disorder and so on. And if you compare the UK NICE guidelines, which are worldwide standard, and the German guidelines, they are very, very similar. You should have a specialist. There is no stratification by severity in the NICE guidelines. But why? Because the prevalence, the administrative prevalence in the UK is much lower. They have a very, the NHS can deal only with more severe cases. So those who are seen by the NHS for ADHD, they correspond to the German more severe cases. So they don't even see the mild cases. Therefore, they do not need to stratify severity. So there is not really a difference between NICE guidelines and German guidelines. ADHD drug treatment should only be given if you cannot change, if there's really impairment. It's the psychological treatment for mild and moderate ADHD. And as I said, the NICE do not have those mild cases, our mild cases in the system. Parent training should not be reserved for just the young children, as in NICE. It does also make sense if they are, let's say, 7 or 8. Probably not if they are 18, for sure not. And that's very important for all of us. Do not use antipsychotics to treat ADHD. We are currently updating this Oxford textbook of ADHD, probably will appear this year or next year. And I would want to thank you for your attention. And I'm now finishing my presentation, and I hope we have time for discussion. So I just wait for someone to give me some signal. Hi. I think Natalia Zerpiak wants to, has raised her hand and she's still muted. I can't do anything about this. This needs to be done by the operator. Is the operator still there? Hello. Anyone there? Sorry, Natalia, I cannot unmute you, and also this needs to be done by the operator, and maybe you can. I put it in the chat. We need. People who raise their hands and they have questions. Okay. Okay. Yeah. Oh, thank you. Yeah. Or maybe you can just give the questions of the people, and I can try to answer the questions.
Добрий вечір. Здається, мене розм'ютили. Я маю питання на рахунок дослідження, про яке ви говорили, що діти не виростають на сантиметр або там не добирають 1 кілограм. То я хотіла спитати, чи проводилися якісь нові дослідження, бо по дослідженнях 1970 року я пам'ятаю, що це було вказано, але потім це спростували через те, що діти в перші 2 роки не добирали той сантиметр, але якщо це було постійне регулярне споживання, то до підліткового віку вони набирали той вік. Тобто це не є виключення і обов'язково там це чи були якісь нові дослідження, чи це те саме дослідження? Бо я читала в Барклі, що там, здається, були вже спростування певних цих.
Thank you for your question. It's the MTA study, multimodal treatment study, and the interpretation is which I cited. And they even do not completely agree on how to finally interpret their findings. I think it's safe to say if there is a risk, then on average it's very small and probably not really clinically relevant. And it doesn't really matter whether you are 1.79 m or 1.80 m, probably. But if you are a small child and already at the lower edge and you have a lack of appetite, then it's probably something that and therefore we should, when we prescribe stimulants, also regularly check whether there are signals for that they move below the age the weight percentile or the height percentile. And we did a study that we just recently finished. It was a multi-site study across Europe, the so-called Adolescent study, where we could only find weight differences for the treated versus the non-treated, and did not see, but it was just a study for 2 years' time, but we couldn't find any differences in height. And the discussion is still ongoing whether there's really a difference in final height or not. But some people from the MTA study would conclude, yeah, there is a minor difference in final height. But I just wanted to mention this for the sake of completeness and that you've heard it. But thank you for your question.
Добрий вечір. Hello, I would like to ask if we have ADHD and some comorbidity, which is borderline personality disorder, anxiety disorder, or depression. With what issue it will be better to start for the best effectivity? How do you think?
Yeah, thank you. That's also a very important question. In general, I would try to start with first the treatment which is more rapidly leading to success, and secondly with a disorder which is more severe. So you can, of course, it's very difficult if you have severe depression to evaluate the level of ADHD, because inattention can also be a symptom in depression, as you know. But on the other hand, if it's a mild depression, then I would go for sure first a treatment with ADHD, because this could also have certain positive aspects in relation to mild symptoms of depression. If it's substance misuse, and this is frequent, this was a huge debate in 10 years ago in Germany, when they would say, oh, you should never treat someone's ADHD if he is, let's say, smoking cannabis. But this is no longer the recommendation. You should really treat the ADHD even if there is comorbid substance misuse. And you mentioned personality disorder of borderline type. Yeah, this is because it's a personality disorder, it's not a really rapid that you can rapidly change something. So usually I would start it's only a problem if you have two medications at one moment in time. You should not enter too many. You should not enter two medications at the same point in time, because then you cannot really easily evaluate the effect of the one or the other. But I would be a little bit hesitant if there is really full-blown mania. Then I would not. Then I would first treat mania, or I would first treat psychosis, and then the ADHD. So it depends on the severity and of the specific disorder. And this is the general rule of thumb. Does this answer your question? There is one question. At what age ADHD can be diagnosed, and what tests are used in young children? So there are no tests for ADHD. It's always a clinical diagnosis, and the clinical diagnosis means that you have to integrate all the different information from different observers, from teachers, from the kindergarten, from the parents, but you also have to evaluate whether they are solid. There may be parents which overstate or understate the problems. Is the same for teachers. So integrating across different context and situation is important for the diagnosis. Also to evaluate whether there's really impairment linked to the symptoms of ADHD. It should not be diagnosed below age 3. But in children which are, let's say, 4 years old, then it's, if they have really very strong ADHD, they are always fidgeting or hyperactive, and very, very hyperactive, then you can see the difference to their peers. But because in young children, there is still a lot of variation in terms of temperament, it's much harder. So the more severe, the earlier you can go. And second part is there are no tests. You can later on, and it doesn't make sense to do neuropsychological tests because there is this comorbidity with dyslexia. And, or for example, that you, in order to get a full picture, you want to have these neuropsychological tests, but there is no marker. You can have a certain attention test for attentional functions, which is not impaired, and you can have ADHD and vice versa. So they are not specific enough. So don't rely on the test, rely on the clinical picture. And this is to bring different rate. You should also not diagnose it only by rating scales, because, as I said, sometimes there is some teachers may have a bias and rate all the extremes, or either to the one side or the others. So it's best if you're unsure to talk definitely through, and then maybe over time it becomes a more clear pattern whether it's really ADHD or something else. So next question.
Good evening, dear professor. I'm Yuri Fields. If I'm fine, or maybe someone else.
No, continue, please.
Okay, please. I would like to ask a few questions, but we will limit maybe not more to two. One is diagnostical. I have a lot of adolescent and adult ADHD patients, yes? And one of the questions that is poorly discussed is if we do...
You're muted now. Fields, you're just muted.
Okay, I'm unmuted again.
Yeah,
so the first question is treatment related. If we have a patient with bipolar disorder, yes, and the first line of treatment is still methylphenidate, yes, and we have different points of view. Should we avoid stimulants in bipolar patients? But there are some opposite information that still there is a sense to keep the patients on stimulants. Nevertheless, they have a bipolar disorder and a risk of mania. Let's say we are talking only about bipolar 2, not the acute mania with psychotic symptoms, at least this population. What is your point of view, and what is the latest information? How would you treat the patient that need both bipolar 2 in depression and in severe ADHD that masking some depression symptoms? And would you allow them to stay on stimulants?
In bipolar 2, I would allow them to stay on stimulants, but I would closely monitor them. But I would, if they are stabilized in terms of the bipolar, I would not refrain from giving stimulants if the stimulants if they profit from the stimulants. But there is, of course, a certain risk. I would, if it's bipolar 1 and they are in an acute bipolar 1, of course, I would get rid of the stimulants first and try to. The bipolar is really a disorder where you or mania, not so much depression, but you are also familiar probably, Fields, with the discussion about disruptive mood dysregulation disorder, because there was in the US, there was a discussion. They said if someone is continuously irritable plus ADHD, this would be the pediatric form of bipolar disorder, and this is simply not true. This is there is a risk between irritability and what you this chronic irritability plus ADHD. They later develop depression, so rather mono, so not the mania, but just the depression. And in this case, there is no reason not to treat with stimulants. But if there's really mania, I would try to stabilize the mania first, and then, if still needed, in case of bipolar 2, also use stimulants, but closely monitor.
Yes, that's self-evident, but we do the lifetime problem ADHD, and we have some elevations of mood and some depressions that are overlapping on a persistent ADHD. And sometimes we are very hard to distinguish what is going on. Is it a mania, or it's overstimulating, or it's ADHD symptoms when the mania is mild? And that's the question. Should we always discontinue stimulants if we suspect that it's not a mania, but some overproductive period in ADHD when we don't have psychotic features?
Yeah, when there are no psychotic features, from a clinical point of view, there are few data and few studies. So you can only make up a clinical mind. And I would say, as long as you need to balance how much they profit, and not to be, if you have it even makes a difference if you know the person very well, your patient very well for a longer time, then you have a different feeling what you can do than if you just have a new patient. There was this, I mentioned the study with the psychosis. I did not explain it in detail. There was this really the worry that if you give stimulants to patients with psychotic, let's say, a vulnerability for psychotic disorders, that you would trigger the psychosis. And it turned out this is not the case. It is simply not the case. But it was an artifact, because as said, many came who have, let's say, attention problems as a precursor of schizophrenia. And then they treat the attention problems, but the attention problems are not real, or the negative symptoms are not ADHD, but a precursor to schizophrenia. And then you try to treat with stimulants, and then you later on develop schizophrenia, but it has nothing to do mechanistically with the stimulants. So I trust, because I understood from your question and from the points that you already consider that you are on a very safe side clinically to continue. If you make up your mind and if you consider all these aspects, then your patients are already in a very good situation.
Доброго вечора. Можна питання? А що ви, як фахівець, порадите проводити, крім медикаментозного лікування з цими дітьми, підлітками з рдугом? Які, особисто ви порекомендуєте методики, напрями?
It depends on what you are aiming at. If it's really the ADHD core symptoms that cause a problem, and then I would definitely advise my patients to I would treat them with stimulants, full stop. However, there are many other, because it's not just a patient with ADHD, it's a patient who is a living person, who has a lot of you know, the adolescents make up their mind. The issues like what I said, stigma is a huge issue sometimes, that they are stigmatized, that they are rejected from peers, that they may withdraw, they have no hobbies, they do no sports, they are not so integration into the society, who have friends, good friends, is something which is very valuable for the development of the children. To boost, not say they should not become narcissistic, but to have a certain, let's say, good self-esteem is something which is important. So all these aspects do matter, and they may matter for all children, but those who suffer from ADHD are probably more, because they are more vulnerable overall, it's more important. So there is room for psychotherapy anyway, and it's also good. I would personally advise my patients not to self-identify as just being ADHD. There are some, in patient group, you sometimes see people who say, oh, I'm an ADHD person, and then they see every aspect of their life just through the glasses of ADHD. But this is simply, not really, I don't think this is helpful. Same if sometimes we are all depressed, sometimes we are all inattentive, sometimes we are all impulsive. This does not mean that ADHD doesn't exist. It does exist. They have certain problems, but you should not say, I'm just ADHD. You wouldn't say, I'm just a broken leg. You wouldn't say, I'm just, I'm just my hip. You're a person, and you have to develop your personal skills, your relations with your peers, with your society, and so on. And this makes you happy. And finally, it's the functional impairment and the quality of life, which does count. Does this answer your question? So there are no specific non-pharma. So behavioral therapy is something, of course, that you can use, for example, to if there is social anxiety, or you can also certain psychodynamic therapeutic principles can be or systemic approaches can be useful if there are certain problems in this. So this is, it depends to evaluate the full picture. Do not reduce the patient with ADHD just to inattention, impulsivity, hyperactivity. I try to bring across that ADHD is very heterogeneous in all respects, and so it's the specific patient. Do not treat according to algorithms too much. This is you need to have the focus on the full patient and the family and surrounding. Yeah. There is a question now. Could you please tell a little bit about the effectiveness of guanfacine and atomoxetine for teens with ADHD, ODD, and borderline disorder? Yeah, guanfacine and atomoxetine have an average effect size of 0.7, 0.6 to 0.7 for ADHD symptoms. They do not really work so well for ODDs. Sorry to say, but this is ODD symptoms. If at all, I would also prefer, if it's reactive aggression, I would prefer stimulants also in these cases, not with antipsychotics and so on. Guanfacine is a slightly different story, because guanfacine, if there's a lot of arousal in borderline disorder, guanfacine may be helpful, and guanfacine can also be used to treat ADHD, but it's just for ADHD symptoms, it's not as effective. So this was a question that I just saw, but then we can go to the next hands that have been raised. someone needs to just start. Or...
Вітаю. Скажіть, будь ласка, існує така думка, що у жінок, ну, у маленьких дівчаток, рдух дуже важко діагностувати, тому що вони вміють вдало його маскують. Чи дійсно це так, і потім тому і це свідчить про те, що така різниця, що у хлопчиків проявляється частіше, ніж у дівчаток, але потім десь вирівнюються ці прояви.
It is true that in adulthood the gender ratios are more balanced. There is still a preponderance of boys, but it's not as extreme as of males. Sorry, but in adulthood, but it's not as extreme as in childhood or adolescence. However, it's a complicated issue. Why? Because the true, and the question is what is true ratio. So epidemiological studies did find a more balanced ratio for between the genders. So 1:2, maybe 1 to 2.5 or so. So one boy for so one girl. And two boys. But in clinical studies, in clinics, you sometimes find one girl and out of 5, so 1 to 4. Now, this has been then, it's also true that girls do present less with comorbid ODD or this aggressiveness or conduct problems. So it's also the comorbidity and more with internalizing symptoms than with externalizing symptoms. But it's very hard to say, and therefore there are some arguments that girls may more easily be overlooked if they have ADHD, because they are shy, because they're anxious. However, there is also evidence suggesting that if you compare those children with ADHD from epidemiological studies, so the boys and the girls with ADHD, then you find that the girls in epidemiological studies are less impaired than the boys, while in the clinical studies they are similarly impaired as boys. So it's a bit a question whether it's a level of impairment leads to the admission in clinics, or whether it's if the criteria for ADHD are fulfilled. So probably multiple explanations and factors do play a role. I would probably argue against that it's just overlooking girls. There is certainly, it's a higher chance that ADHD is overlooked in girls, and you should not ignore symptoms of inattention in girls if they do not also are as prominently hyperactive, impulsive, but it's still a preponderance of the male gender, or the male sex, sorry. Then, next question. I still see a couple of hands.
Dear Professor, thank you so much.
You are now again muted.
Yes,
yeah,
now.
Yeah.
Okay.
I can't hear.
Yes, now it's okay.
Yeah, yeah.
Yeah, thank you so much, Professor. Could you also answer, is it possible, and it's possible, but how it will be better? What main stones for distinguishing the ADHD and borderline? Because usually these symptoms could be in behavior, very similar, some of them. And also if teenager, for example, has ADHD and also very impulsive behavior, and the symptoms that are alike with borderline disorders, is it possible to distinguish, and what would be the better treatment?
Okay. So what I would refer to is what I would refer to is or what I would focus on is it doesn't really make borderline personality disorder is not just impulsivity. You have impulsivity, but the core feature and probably the distinguishing feature is this black and white register. You know, that the problem in intimate relationships where they break off always and can either see a person as very close friend or as an enemy, and nothing in between, you know, no black and white. And this is something which you wouldn't expect. Just ADHD people are sometimes impulsive, but they are more or less they get along well. They haven't got this specific feature, so this could be a distinguishing factor. And on the other side, what else? Yeah, of course, borderline personality, patients with borderline personality disorder could also be inattentive, but it's more like the dissociation and all these specific psychopathology which would qualify for a diagnosis of borderline personality disorders, and I would rather be a little bit careful in children or adolescents and of course self-injurious behavior is also not specific for just borderline. You cannot diagnose if patients with borderline personality disorder only because they cut themselves, for example, because this is a very broad phenomenon in children. But if you have an adult that cuts himself, then it's much more has more prognostic value in terms of borderline personality, because it's the context of the symptoms or the age context, but also the cultural context may change the prognostic value of the symptom. And I would and the point that you made, it's really, there are overlapping symptoms, and it may also be a comorbidity, you know, that girls with ADHD have a higher likelihood of later developing borderline personality disorder, also because of the ADHD and maybe entering difficult situations, maltreatment or sexual misuse and so on. And so there is emotional dysregulation. So we have a unit for adolescents with emotional dysregulation. Then we have adolescents with ADHD, but also with borderline personality disorder. So that's what you mentioned. There are certain, the emotional dysregulation or the emotional impulsivity is surely present as a transdiagnostic feature in both these diagnoses.
Yes, yes. And what would be, please, Professor, what would be better treatment if, for example, ADHD teenager has borderline informing?
For borderline personality disorder, I would clearly think that DBT, so dialectic behavioral therapy, can be very helpful. This is a psychotherapy that has been redeveloped. But I would also then, if they have both ADHD and then I would go for stimulants plus stimulants may reduce the emotional dysregulation to a certain degree, but it will not help with all the, let's say, relationship problems. So you need to combine psychotherapy, like dialectic behavioral therapy, with, for example, stimulant treatment.
So stimulants will be okay, or stimulants with, for example, antidepressants in case.
Yeah, yes, sorry, of course, yeah. If there are SSRIs are helpful, can be helpful for emotional dysregulation, but also for the depression. And of course, there is no reason not to combine the SSRIs or the antidepressants with stimulants. I wouldn't go for tricyclics, but rather SSRIs.
Mm-hmm. Thank you so much.
Thanks. So next one. There are still hands. I still see hands up in this on the screen. Does someone want to ask a question? I can't do anything about these hands. So yeah, okay.
По-перше, дякую за таку чудову наступну лекцію, за можливість послухати вас. У мене є таке запитання. Скажіть, якщо до нас приходить пацієнт, не діагностований раніше з РДУХ або з іншим психічним розладом, і от по симптоматиці, наприклад, і на афективний розлад схоже, і на і на розлади особистості схоже, так? Як ми діагностуємо, тобто це буде і розлад дефіциту уваги, чи це може бути і той розлад? От як саме цю діагностику зробити?
Okay, yeah, got it. So let me start with something that you know, but that we should remind ourselves. So the diagnostic systems that we develop and that we agree on, be it ICD, be it DSM, and that we change over time with new diagnoses or different criteria, these are useful categories that we develop to, let's say, classify the world into categories, the cases into categories. But the question is really, are these categories natural entities? Probably not, because the more we know and the more we study the groups that fall of patients that fall into a certain category, the more we see that the categories in itself are heterogeneous. And that so on the whole discussion about transdiagnostic symptoms like emotional dysregulation, which can occur in different behaviors, occur in different diagnoses. It can be inhibition problems. It can be that which are not specific. It can be emotion dysregulation problems that be that are non-specific, and so on and so forth. So what's important is, and I'm not saying that the disorders are not valid or that they are not useful, but I just say they are useful for our communication and to capture a certain problem, but it's not either or, and it's not a natural entity. And sometimes the patients do not fall into just like if you have, it's not like in the somatic medicine where you can say, oh, it's either this bacterium or it's another virus which causes the problem. There are the etiologies or the pathophysiology of problems. They are multifold. It's mostly an interaction of psychological, biological, genetic, environmental factors. So it's a mix in a certain way. So this set up front, I would say you should ask, for example, if you want to say, is it ADHD or is it bipolar disorder or is it attachment disorder? Attachment disorder, the mainstay of attachment disorder is really this problem with the attachment. So they do not bind like normal children to, they have either very loose binding or, I don't need to explain to you, I think, attachment disorder. And of course, they can be inattentive and so on. So I would, and you can have many who have ADHD plus attachment disorder. So it's, I would probably not ask too much, should I, is it this or that in terms of a differential diagnosis, but rather, and also not, is it just for just the diagnostic criteria formally filled, but rather try to inspire your mind in terms of treatment, because the treatment does matter. You have the problems, the treatment, and then you can think, okay, if it's really attentional problems, impulsivity problems, hyperactivity, why not try out, let's say, stimulant? So, for example, or if there are attention problems and no formal diagnosis of attachment disorder, but attachment problems in case of ADHD, because there are links between both disorders, then why not try certain psychotherapeutic interventions to help to overcome the binding problems? So you see, the logic that I'm aiming at is classify the problem areas, try to address them. So, for example, if you remember the whole discussion about, is it autism related inattention or is it ADHD? And finally, meanwhile, we changed the system, the diagnostic system. Now you see that those who fulfill diagnostic criteria for autism, many of those also, or some have really attention ADHD problems, some have not. If they have ADHD problems and autism, of course you are more careful to medicate them, but you can try out and see whether it helps them. Or the question is always, does it help the patient or not? So that's also why I'm not so in favor for just, if someone has oppositional problems and you and just put antipsychotics in, and then they are just sedated and cannot move anymore, and so you have no oppositional problems. Yeah, that's not a way how to deal with people and persons. Enable them that they can develop, that they can grow up and learn competences in the social sphere, but also in the academic sphere, and then you can see whether it helps them or not, and then reevaluate. So that's something I can't, there is no strict rule up front. Does this answer?
Дякую. Так, звісно, дякую. І ще скажіть, будь ласка, якщо от рдух, він сам може бути без будь-якого коморбідного розладу? Бо от я з таким не стикалася в своїй практиці, але можливо таке є.
Yeah, no, that's yeah, you have probably not seen it in your practice, because if it's just ADHD, then the patients may also do fine in the world and do not care. So for example, in Germany, you have quite some glamorous film stars, academics, who sometimes people may cope. They may cope, and if someone has nothing but ADHD, he may just not show up in your clinical practice because he doesn't regard it as a reason to be treated. There are cases, but it's a minority of cases with no comorbidity or no additional problems. So maybe 30% or so. So 50 to 70. I think 70 once, it depends on the age range, but 70% have at least one comorbid disorder, be it dyslexia, be it, and some have multiple. So no wonder that you haven't seen it, those patients in your clinic. And the better you look, the more you see. That's also clear. So you should not worry too much. Next question, please.
I guess we will take just 3 more, and that will be it.
Okay.
Добрий вечір. Можу задати запитання, так?
Yes.
Yes. Дякую. Підкажіть, будь ласка, така ситуація. Маємо дитину 10 років, зараз з 9 років приймає атамоксетин. Скажіть, будь ласка, чи може покращитись ситуація з проявами РДУХ, можливо, після 11 років, що пишуть в деяких виданнях, що процес мієлінізації грає теж важливу роль, що може у дитини поведінка змінитися. Наприклад, якщо там йдеться про імпульсивність, непосидючість, неуважність, а в принципі дитина дуже комунікабельна, тягнеться до дітей, але має ще таку ваду, дуже дитяча така поведінка, трошки не за віком. Він доганяє, ось так, як ви казали, 2 роки. Ось це і спостерігається, коли порівнюєш дітей на 2 роки менше, то у нього така поведінка. Чи може змінитися? На що сподіватися? Як бути? Чи потрібно перерву в прийомі препарату робити, щоб подивитися, як дитина буде вести себе, наприклад, після 11 років? Як поспостерігати? Правильно зробити висновки?
Yeah. So first, if you remember the slide where I show the persistent rates over time into adulthood, then you can say, depending on how you define persistence, it does change. And there are a substantial number, and it's a minority, but it's a substantial minority of cases who have ADHD problems in childhood, but do not continue to have so, or adolescence, but when symptoms become lower. And so when they mature, when they become more mature, as you said. So yes, in principle, it can change, and sometimes in some patients it may stay, but it's always good to see that it does change. We don't really know what the factors are which drive change. I personally, but that's just a belief and not because there are no studies, that it also depends on what people do with themselves. You know, imagine you are interested, become interested, and read books and develop certain strategies, compensatory strategies. You get a lot of good feedback for your reading books or whatsoever. You build up your mind, and if you build up your mind, then you have more potential to deal with the problems that you're facing. So you have to keep a long time perspective. It's probably not from one year to the other that things change dramatically, but I know many patients personally that are treated where it was a problem, and then there was a critical period, and after some years it became less of a problem, or there may be critical time periods again. For example, if they leave home, go to their job, their university, have to live on their own, have no more the structure they had before, then it becomes more difficult. They may be more bored than others. So it depends on the whole situation. But the patient that you have described, if it's just a little bit childish, but is still not rejected by the peers, because to be integrated in the peer group, to develop hobbies is very, very important, where they can also get not just fun and satisfaction, but also develop certain self-esteem. So these are aspects. Now with it's not obsolete. No, it's not obligate. Sorry, not obsolete. It's not obligate you. It's not that you have to do a pause every year, but you should evaluate whether the medication is still working or useful. Let's put it so. For example, if the symptoms are fully covered by the medication, and then you cannot say, "Oh, I continue with the medication until the rest of the life," because you don't know whether, as you said, whether the symptoms are still present without the medication. That's something that you cannot assume. So from time to time, you should reevaluate. That's more easy for stimulants, because if they do not take it, let's say, for a few days, and then they become very hyperactive, then it's easy to see. But with atomoxetine, it always takes quite a time to get it out of the system and then to get it into the system until it is working. So I would probably be somewhat more flexible in so not to do it every year or so. It depends also how the child is doing with the medication and so on. I don't know why he's now on atomoxetine and not stimulants, but of course, if he profits from the stimulants and he's still childish, I would wait a little bit, because the maturation there is no and this was only done for stimulants, but not for atomoxetine. So the ADHD medication was not the MRI studies, the developmental MRI studies by Philip Shaw, and so they're rather those who were treated with stimulants were better off in terms of brain development. So the brain development was less deviant than those who were not treated. You cannot conclude that the methylphenidate is or the ADHD medication is helpful for brain development. The conclusion would be too far-fetched. But it's not, at least you can say it's not harmful. Possibly it has a positive effect, but it could also be confounded, because parents who say, okay, I try to medicate it may be other factors which are just associated with the use of medication, which are responsible for a better maturational curve, brain curve. But what you can take as a take-home message, that there is no indication that any ADHD medication would impede brain development. Okay, then we have two more questions. Yeah. No, I can give a short answer. No, not really. There is a discussion. We had this discussion in Germany as well, but I don't think there are any studies suggesting that this is worthwhile. But it's a little bit like it's a lot. It's more. No, no. I leave it with this. It's not evidence-based.
І, шановні колеги, ми беремо останнє запитання сьогоднішнього дня.
Дякую. Я не є лікарем-психіатром, я навчаюся на корекційній психопедагогіці, тож з точки зору спеціального педагога моє питання наступне. Ми також маємо змогу працювати з дітьми з ОРДУХ, надавати певну підтримку у навчанні і у корекційній роботі. Тож, які би ви дали поради спеціалістам, які не мають медичної освіти, та клінічного уявлення про ОРДУХ, що таке основне нам необхідно знати про цих дітей?
Yeah, I think a good strategy would be that you build together with others a certain competence network, including doctors, but also pedagogues, and also that you have exchange where you can, for each case where you are a little bit unsure, where you can discuss this with your peers, so colleagues, with the medical doctors, and so on and so forth. But then in terms of the more narrow question, what is important that you should not say it's either medication or psychosocial treatments. You can the combination can be more effective than it's not, because as I said, the medication may not address all functional impairment problems and vice versa. You may not cure the ADHD symptoms just with the behavioral interventions. Important for you is the issue of the crucial issue of self-esteem, that you should put more emphasis on positive feedback, because these children frequently get negative feedback, not just from teachers, but also in the families. All these issues, experiences which those children frequently have, and not all, but many of them frequently have, that they are rejected by peers, and so are issues that you need to deal with when you do with them psychagogy and so on. I hope this answers your question a little bit.
Дуже всім дякуємо за цей ефір. Дякую, професор Tobias Banaschewski. Дякую, професор, що ви так довго з нами були і так довго відповідали на питання.
I want to thank you also for your interest. I hope to see some of you soon in the future in a more peaceful environment. And I very much hope that now with this, sorry to say, but with this US, I'm not a fan of Trump, but that the support for Ukraine will continue, and that we soon will see peace. Also, I have certain doubts about Putin. If he does not get if there's not a strong coalition, then it's very difficult. I'm very sorry for your people and all those who suffer, and who suffer much more than we are suffering in the West. Also, but that's really, war is also for the children. It's a disaster, and so sorry. I can only say that I hope that we find it, and that we should seek solidarity and support from Germany and other countries, your country. Thank you.
Дуже дякуємо, професоре, дуже дякуємо всім, хто нас дивився, і тим, що дякую окремо за те, що ви такі активні і у вас стільки запитань. І це був перший раз в історії, коли ми перевищили 500, навіть 70 людей в одному зумі, тому наступного разу прямо будемо відкривати на 1000, бо зрозуміло, що вас кожного разу стає все більше. Дуже всім дякую, мирної, тихої ночі.